Hi, this is Dr. A with another clinical chemistry review. We're going to look at GI and pancreatic diseases. Okay, so let's start with diseases of the pancreas. We'll start with cystic fibrosis. So it is also known as fibrocystic disease of the pancreas and mucoviscidosis. That one's hard to say. And it's an inherited autosomal recessive disorder. It is characterized by dysfunction of the mucus and exocrine glands throughout the body. It is a multi-organ disease affecting the lung, liver, pancreas, and GI system mainly. The manifestations are intestinal obstruction in newborns, excessive pulmonary infections in childhood, and pancreatogenous malabsorption, especially in adults. Now, obviously, since this is genetic, it is present at birth. It's present as a newborn. It causes ducts and acini to dilate and convert into small cysts filled with mucus, and it prevents secretion from reaching the duodenum. So many patients have pancreatic insufficiency and need to take digestive enzymes, and this is for every time they eat for the rest of their life in order for them to digest their food. Otherwise, they can't absorb their nutrients and start to get really sick and anemic and all of that. You can also see in this picture a representation what a healthy trachea looks like in a patient. With a cystic fibrosis patient, you have an increased mucus secretion, and the problem here with their genetic deficiency or the genetic problem in cystic fibrosis is that the mucus itself is really thick, and so it's hard to get it out and kind of get stuck in the lungs. So let's look at a few others. We have pancreatic carcinoma. It is the fourth most frequent form of fatal cancer. This one is definitely not a good one at all to get because it's very hard to treat. It causes about 38,000 deaths each year in the United States, and that represents about 7% of all deaths from malignant neoplasms. Most tumors arise as adenocarcinomas of the ductal epithelium. Then you have pancreatitis. Pancreatitis is an inflammation of the pancreas, and it is caused by the autodigestion of the pancreas as a result of either the reflux of bile or duodenal contents into the pancreatic duct, or the digestive enzymes that are normally in an inactive form as zymogen get activated in the pancreas itself. The pathologic changes in pancreatitis include acute edema, cellular infiltration, intrahepatic and extrahepatic pancreatic fat necrosis. So let's distinguish a little bit between acute and chronic pancreatitis. So acute pancreatitis often resolves itself, but it can be life-threatening and it can cause hemorrhage, so it can be really dangerous. Common causes of acute pancreatitis are gallstones and heavy alcohol use. Symptoms are severe abdominal pain, fever, nausea, and vomiting. And for the diagnosis of acute pancreatitis, you want to look at serum amylase and lipase. And lipase is more specific, and elevated amylase levels can be due sometimes to salivary amylase elevation due to mumps. So again, lipase is more specific to the pancreas itself. Chronic pancreatitis is a result of long-standing damage to the pancreas. The most common cause of chronic pancreatitis is persistent and heavy alcohol use. The blood tests for chronic pancreatitis are not as helpful as in acute pancreatitis. The amylase and lipase results in chronic pancreatitis can be normal. So pancreatic diseases can result in a severely diminished pancreatic exocrine function, so it's not secreting those digestive enzymes, and therefore that compromises digestion and absorption. Celiac disease and Crohn's disease can also cause malabsorption. So what is malabsorption and malabsorption syndrome? When you have malabsorption syndrome, there's abdominal bloating and discomfort, frequent passage of bulky malodorous feces, so it stinks, lots of poop, and it stinks, and very loose, and you have weight loss. And this is due to the failure to digest or absorb fats. This is known as diarrhea, and it gives you a greasy appearance to feces. You can do a fecal fat test. But basically, with malabsorption syndrome, if you're missing the enzymes or not producing enough enzymes, or there's problems, the fact that you're not able to break the big components down and absorb them, then that causes a lot of problems in the GI tract. Again, with the bloating and discomfort and all of that kind of stuff, and then you're going to have weight loss because you're not getting nutrients even though the person eats. So let's look at peptic ulcers. So we're going to move on to the diseases of the GI system. So a peptic ulcer is a mucosal break in the stomach or duodenum. The main cause is a bacteria called Helicobacter pylori. Usually you want to do a gastroscopy for diagnosis. So this is for a medical imaging test where they put the tube down the throat and go down and look with a camera and find these ulcers in the stomach and or the duodenum, and they go through the mouth, down the esophagus and stuff. You can do serology tests also. You can do an IgG, IgA, and IgM to H. pylori, much less invasive, and a lot of times the first test to be ordered. There are also some breath tests that can be done. They use radioactive carbon atoms in the urea to check for urease activity from H. pylori. The CO2 exhaled is radioactive if the test is positive. There's also a stool antigen test, again, less invasive, and it can detect active or recent infection by H. pylori, looking for the antigen, the H. pylori antigen. So the next GI system disease is Zollinger Ellison syndrome. It is a benign non-beta islet cell gastrin secreting tumor. It stimulates excess production of hydrochloric acid. The symptoms of Zollinger Ellison are peptic ulcers, gastric hypersecretion, so you have a lot of gastric acids, diarrhea, and steatorrhea. The diagnostic tests are that gastrin is the lab test used to diagnose Zollinger Ellison syndrome because you have an excess production of gastrin. The patient must fast for 12 hours prior to the test, and the gastrin levels can be as high as 10 times the reference range in Zollinger Ellison syndrome, and that is also why you have this excess production of hydrochloric acid. Another type of gastrin test used is one where the patient is given secretin and multiple gastrin levels are drawn at timed intervals. So next disease of the GI system is diarrhea. Diarrhea is defined as loose, watery, frequent stools. Acute diarrhea is short-lived and self-limiting. It's usually caused by infectious agents. Chronic diarrhea can lead to complications such as dehydration and low potassium levels or low electrolyte levels. Causes of chronic diarrhea are ulcerative colitis, Crohn's disease, irritable bowel diseases, celiac, malabsorption, food intolerances, chemotherapy, and radiation therapy. And then for the lab tests for diarrhea, you can do stool cultures, ova and parasite testing, and immunoassays for different infectious agents can all be performed to rule out infection, especially if it's an acute infection, or if it's an acute diarrhea. Then the fecal fat can be qualitative, quantitative, can be used to assist in the diagnosis of malabsorption or maldigestion disorders. So that would be for chronic diarrhea. So let's look at the inflammatory bowel diseases. So ulcerative colitis and Crohn's disease are inflammatory bowel diseases. Both have remissions and exacerbation periods. So patient gets better, patient gets worse, patient gets better, patient gets worse. The cause of both is unknown. There is a possible autoimmune connection and a genetic component with environmental factors as well. So it can be diet, but it can be exposures to various chemicals and things like that. We really don't know. Diagnostic tests are the CBC and fecal examination for white cells, the presence of white cells in fetus, in the feces, sorry. The IBD panel, it has an ANCA assay, with myeloperoxidase antibody tests and proteinase 3 antibody tests and Saccharomyces cerevisiae, IgG and IgA antibody tests. Patients with ulcerative colitis often have a positive PANCA, which stands for perinuclear staining associated with MPO antibodies, showing perinuclear staining associated with MPO antibodies. The Saccharomyces cerevisiae, IgA, and IgG antibody tests can be positive in either conditions. Some of the difference also between ulcerative colitis and Crohn's disease is where the ulcerations and the problems are located, by the way, but that would be something that had to be seen with a lower GI. The next one is diverticulosis and diverticulitis. So a diverticulum is a pouch in the large intestine. So you can see here these pouches that are formed. Here's another representation here. They're not supposed to be there. If there's inflammation then in these, it's called diverticulitis, but the diverticulum is the pouch itself. And diverticulosis is a condition of having these diverticula here. You can do a CBC to detect infection or inflammation, but really you need a CT scan to visualize it. And then they have problems with food and seeds and different things that can get trapped in these and be painful again and cause inflammation and things like that. So lastly, we have tropical sprue and celiac sprue. They both lead to malabsorption. Tropical sprue is from the overgrowth of bacteria. Celiac sprue is an autoimmune reaction to gluten. The laboratory test, although the gold standard for diagnosis is on either disorders is a biopsy. This is usually a test of the last resort because it's so invasive. We've had advances in serological testing for celiac disease. We have HLA testing, so sometimes you don't need a biopsy. You can look at some of the tissue transcriptaminase tests and all of that, antibody tests. Tropical sprue needs a positive stool culture to aid in the diagnosis, so that would be obviously showing that overgrowth of certain types of bacteria. That is the last one. Thank you.